Good morning, and welcome to this session, which I think is going to be very interesting and perhaps even entertaining. At least that was the intent when we planned this program. And of course, we planned this program with the idea of making it very entertaining, but also very scientifically sound. So we have phenomenal speakers, and it's a privilege for me to share the podium with the two co-moderators and also to introduce the speakers. So what we'll do is we'll have the speakers give their lectures, and then maybe you moderate the discussion at the end. So with that, I would introduce the first speaker, John Morton from the United States, who will address the topic of how you choose the surgical procedures. Should it be a patient choice? Should it be a surgeon choice? Or should it be an evidence-based choice? John.
Thank you. I want to thank Dr. Rubino and our moderators, especially Dr. Cohen, our future president for IFSO. We should give him a round of applause. But it's an honor and privilege to be here at IFSO in a beautiful city, and happy to discuss a little bit about where we stand in 2023 in treating type 2 diabetes in patients with obesity. Here are my disclosures. In terms of cases, I've done about 4,000 gastric bypasses, about 2,000 sleeves, 200 bands, and about 3 SADIs. So if we look at how people have approached the cases, we can say, if you will, that the people and surgeons have voted with their feet and hands. We can see that the sleeves have grown tremendously in the United States, 5-fold. Revisions have as well. Both bypass and DS have remained pretty flat. Of course, the band is going, gone. So in many different ways, I think people are seeking out the sleeve for whatever reason. Surgeons may be seeking it out because, frankly, it's a lot easier to do than to do a bypass. Patients are looking, I think, invariably for less invasive, not more invasive. But if we look at some of the data behind it, for example, the new indications that came from IFSO and ASMBS, they are recommending clearly patients should have surgery if their BMI is over 35, and then it should be considered with metabolic disease such as diabetes between 30 and 35. The one thing here, though, is that there wasn't a clear declaration as to which procedure. It just said metabolic and bariatric surgery. So there's no clear direction, at least from indications, which procedure should be done for metabolic syndrome. You can see here for patients, again, that it's simply recommended for type 2 diabetes and BMIs over 30. But again, not a clear direction as to which procedure would be best. But it's a step forward, clearly, with the new indications. This is a study I did a few years ago, just comparing my case series of roughly about 5,000 patients at that time. And it was looking at comparative effectiveness between procedures. We know the results in terms of change in BMI, and the change there clearly favors bypass, sleeve not too far behind. And then I think there's been a lot of discussion, particularly from our medical colleagues, is it all weight loss? And the big question here is it another weight-independent effect? And what you can see here through a correlation slide is that when you correlate the amount of weight loss and the remission of diabetes, and in this case is measured by hemoglobin A1C, there was no correlation between bypass and weight loss. So it does appear there may be some weight-independent effect for the bypass. For the band, it's clearly correlated that we saw here in this case with patients, and also the same for the sleeve. So weight drives the improvement in diabetes remission, at least in this study. So that's some of the things that we saw, that there may be some independent effects for Roux-en-Y, and I think we'll hear more about that later. We also looked at it in other directions, like cardiac risk factor improvement, and then you can see the different procedures arrayed, everything from bypass in blue, sleeve in orange, and band in green. Clearly that both the sleeve and the bypass do much better than the band does, but pretty close in a lot of different directions. We look at fasting insulin. Again, there's almost a stepwise approach with the bypass being favored. And you can also see that with triglyceride HDL ratio. That's actually an important little ratio to remember. Metabolic syndrome is something that drives a lot of the endocrinologists, increases your risk of cardiac death sevenfold. But a simple shorthand, instead of going through all the ATP3 criteria, is just a triglyceride HDL ratio greater than 3.5 is indicative of metabolic syndrome. You look at some of the emerging cardiac risk factors, and you can see there's positive changes for them all, but bypass is predominant, particularly for high sensitivity C-reactive protein, marker for inflammation. We're learning more and more that a lot of our disease process is being driven by inflammation. And if we look at it again altogether in terms of improvement, again, the bypass is considerably better than all the rest. Now, if we look at what predicts improvement, a few things to notice here is the bypass is better, for improving C-reactive protein. And here, if you look at that metabolic syndrome, and again, the marker for this is triglyceride HDL ratio, there are a few things to note here. One is both the bypass and the sleeve are going to improve it. Things that will hold you back is BMI greater than 50 or age greater than 50. And I think we're learning that BMI greater than 50 in many ways is stage 4 obesity, disseminated obesity, harder to eradicate, and perhaps we need to look at that in a different way in the future with multimodality therapy. And this is another example of where we see improvements with both procedures, Roux-en-Y. This is testosterone. We need to address the male population. We are not seeing enough males come to see us. It's only 20% of our cases. Maybe this will bring them into the operating room. You can almost double your testosterone following gastric bypass. But you get pretty good improvements as well with the sleeve. So that's another thing to kind of note, is that even with the sleeve, you're going to get improvements. I think anytime you approach anything in medicine, you have to have a risk-benefit analysis. So does the benefit outweigh the risk? And this particular study just came out this year. I don't know if people have seen it, but it's a really important study. And it's from Dr. Ted Adams, who you guys know from the Utah study, that was one of the first to demonstrate a life expectancy benefit to bariatric surgery. Now, his original study was just bypasses, but now he's continued. He actually has almost 40 years of data, 40 years. And so what he did is he looked at the different causes, different procedures, and see what kind of improvement they would have for survival benefit. And this was surprising to me. The sleeve had the highest benefit. Now, we know that the bypass is better for diabetes remissions and things like that, but it does have an Achilles heel, and that is the issue with alcohol use afterwards. So, and if you look at the other highlighted box, this is survival benefit rendered in the setting of diabetes. You can see there, again, it's a little surprising, but the sleeve comes out better. And this is population-based data. Again, the reason why we don't see maybe as much improvement with the bypass is because of its effect on alcohol metabolism. You can see there on the left, there is a definite association with the bypass, not the sleeve, when it comes to alcohol metabolism. And it becomes manifested through decreased survival benefit. And the reason for it is pretty simple. We have alcohol dehydrogenase receptors in our stomach and in our liver. And if you bypass it, then you're going to not be able to metabolize alcohol appropriately. Many years ago, I did the study showing that if you have a gastric bypass, you will have higher peaks. It will take you longer to clear that. You have no alteration in alcohol metabolism whatsoever when it comes to the sleeve and the band. I followed up the same study with some of our gastric cancer survivors. They had the same alcohol metabolism as you would find with a gastric bypass. So it was not psychology, it was simply physiology. One of the ways that you can help decide is a shared decision-making model with your patients. And this is a tool that I'm proud that we brought out from MBSA Quip. We were able to take advantage of over 800,000 observations. And with it, you're able to go over patient data. And this is free and available to anybody all over the world. So if you want to take a look at where that risk calculator is, you can use it. You put in the demographic data, age, gender, diabetes, insulin use, et cetera, and then you can put in which procedure, and you calculate it and you show it. And if you look there, it shows the diabetes remission rates, in this case between sleeve and bypass. And then you can also see the weight loss curve, which for us has become very important. When patients deviate from that weight loss curve at 3 months, and we can predict future weight loss as early as 3 months, then we see if they need to augment their therapy with other things like anti-obesity medications. This is Phil's study from Stampede, and it's, I think, obviously a very powerful study. It's randomized. But if you take a close look at between the performance for the sleeve and the bypass, they were pretty close, particularly if your BMI is under 50. So it's something for all of us to consider. What do we do with those higher BMIs? I've already hinted at the BMI greater than 50 being disseminated obesity. A couple of things we know is you're going to have more heterogeneity in terms of weight loss when your BMI is higher than 50, and it doesn't matter which procedure. This is data that I published a few years ago, but you can have variation even with the gastric bypass. So what do? One of the things that we do is identify those at risk. Who's at risk for not losing significant enough weight? Those are people with BMIs over 50. So I think we have to start approaching them in a different way. You know, 20 years ago when I first did bariatric surgery, I was high-fiving everybody when we did a BMI over 70. Now I have the benefit of seeing that patient 5 or 10 years later. They're still pretty big. And so we still have to figure out different ways of approaching these patients that have a BMI greater than 50. One of them could be losing weight prior to surgery, taking a model from oncology with using neoadjuvant weight loss. And just like they do, they can shrink the tumor. Maybe we can shrink the patient prior to surgery. And we have seen some interesting findings about pre-op weight loss. There's a study that just came out not too long ago, and it found that patients who lost weight before surgery with a mark of at least 10% actually had reduction in mortality at 30 days, actually had reduction in leaks. We need to see if that carries forward in terms of future weight loss and improvements in diabetes, but intriguing, 500,000 observations. The study I did just recently shows that we can achieve that 10% weight loss 10-fold times better when we use the anti-obesity medications like semaglutide. And this is a study that we're looking to complete, and this is what we call the MATTERS trial, and the idea is that you use some of these medications prior to surgery as well as after the surgery. Anybody know who this gentleman is? This is Bernie Fisher. Dr. Gagne, who's a historian of medicine, knows him, and he was the first one to say that, you know, cancer is a systemic disease, and so we should approach it in that manner. So he's the one that advocated for radiation chemotherapy for breast cancer before operating on them. And so maybe we need to take those kind of approaches as well so we can safeguard our results. So in choosing the operation, I don't know where the band rests now. I never did a lot of them, but I think, I guess it's up to patient. I think we've had discussions about even removing the band from as an approved procedure. I think the sleeve works in a lot of different areas, specifically BMIs 30 to 50 and some of those other indications there. I think the bypass is the best anti-reflux procedure we have. Duodenal switch is a very powerful operation, a lot more benefit, little more risk, so you have to use it judiciously. And so with that, I just wanted to point out, we also need to figure out the new players in the game. I took this picture at ASMBS, and I thought it was telling. You know, they ran out of information about Wegovy at the ASMBS meeting. We need to figure out our role in the future, how we're working with these medications, and I think metabolic centers will be the way to go in the future where we're all working together. That's what we have at Yale. We have a Center for Weight Management, and we all work together there, both in nutritionists, psychologists, surgeon, anti-obesity medicine specialist, and that's hopefully how we're going to get the best results. This is my university, which is older than America, and again, I really appreciate the opportunity to talk to you all today. Thank you, Dr. Rubino.
Thank you, John, for also being very much on time. I'd like to introduce the other moderator, Professor Vincenzo Bruni, and maybe give you the opportunity to introduce the next speaker.
Okay, thank you very much. First of all, I want to thank Luigi Angrisani for inviting me in this beautiful meeting and this very, very interesting session. So let me introduce the next speaker, who is Dr. Philip Schauer, one of the former president of the ASMBS and one of the master in metabolic bariatric surgery. He will speak about safety and efficacy outcomes of sleeve versus gastric bypass, review of the evidence. Thank you very much.
Okay, great. Good morning, everybody. I'm Phil Schauer, and I'm from the Pennington Biomedical Research Center in Baton Rouge, Louisiana. I'm also director of the Metamor Metabolic Institute. This is a comprehensive multidisciplinary obesity treatment center in Baton Rouge, Louisiana. My talk will be somewhat complementary of Dr. Morton's. I'll be reviewing some of the key components in the literature, comparing gastric bypass with sleeve gastrectomy, particularly related to type 2 diabetes. Now, mind you, this is a 15-minute talk. There's tons of data, so we can't present everything. But let's just start off with the safety. And we should all concede that the two procedures, the sleeve gastrectomy is slightly safer in terms of the 30-day complication rates when you match patients based on comorbidity, BMI, and key demographics. And then we should certainly concede that long-term, some of the nutritional issues definitely favor the sleeve gastrectomy in terms of absorption of some key nutrients, iron deficiency, for example, vitamin D, and a few others. But frankly, rarely do these contribute to major morbidity or certainly mortality between those procedures. Now let's talk about the major efficacy points. And these operations, we believe most of the benefits are driven by weight loss. So here's a very large, big data study from the PCORNet group, authored by David Arterburn, looking at long-term weight loss, comparable patients, that are matched between these three operations. And you see there's a pretty significant gap at 5 years between the bypass and the sleeve, almost as big as the gap between a sleeve and a gastric band. So that is significant. I think this is pretty reliable data, 46,000 patients. And then from the same group, multi-center group, almost 10,000 patients looking at not just weight loss, and again we see a superiority of the bypass over the sleeve in terms of weight loss, but also in the key measurement of glycemic control, A1C. You see here a significantly greater reduction in A1C after bypass compared to sleeve gastrectomy at the 5-year mark, which is very important. These are chronic, progressive disease, so long-term control is really the key here. And then when you look at other parameters of glycemic control, such as remission, again, in this large study, matched patients, the bypass was superior in terms of remission. You can argue that maybe it's fairly modest overall, but it was also superior in terms of relapse rates after remission over time. Patients that had the Roux-en-Y bypass had a much lower relapse rate that was statistically significant compared to the sleeve gastrectomy group. Now, in our own experience, this was in Cleveland, looking at our 5-year data, comparing the three major operations in a very large data set. We looked at remission rates at 5 years with the procedures. We looked at both short-term and long-term. And nowadays, we don't use partial and complete remission anymore. We use just remission, defined as an A1C less than 6.5 on no med. So you can batch these together. For the bypass, in this cohort, about 60% remission at 5 years. For the sleeve, about 30%, so a big difference there, and also a higher recurrence rate with the sleeve. And both of these were obviously superior to gastric banding. So just another data set of long-term data. Now, we also looked in even a larger data set from a group in Cleveland, total weight loss out to 5 years, and again, change in A1C favoring bypass over sleeve gastrectomy. So from these large observational data sets, I think the data is pretty conclusive there, which operation causes better long-term weight loss and glycemic control. Now, what about the randomized controlled trials? These are much better scientific instruments, especially to weed out some bias which can occur in patient selection, particularly in these large observational studies. So let's just start with the STAMPEDE trial. Dr. Morton did reference that earlier. It is true at 5 years, when you look at the change in A1C, the bypass and sleeve were fairly comparable. But when we're looking at these diabetes studies, we have to remember that it's not just A1C, it's what other medications are the patients on to achieve that A1C. And when you drill down in that, first of all, there was a higher remission for gastric bypass versus sleeve in the study. But when you look at 5 years, the medications, almost half the patients with gastric bypass were on no diabetes medications and achieved that A1C mark. But many more patients with the sleeve required additional medications to achieve that mark. So you could argue, yeah, the sleeve could be as good as the bypass if you pile on a bunch of additional drugs, but ultimately what we're trying to test is, what is the effect of the operation on treating the disease independent of medications. And of course, we also saw superior weight loss, which is clearly one of the major drivers of diabetes control. We saw superior weight loss with the gastric bypass in the STAMPEDE trial. Now, what about some of the other very elegant randomized controlled trials? Now, these others that I'm going to show you, the sleeve pass, SM-BOSS, and others, were really not designed to look primarily at diabetes. These were designed for weight loss, so weight loss was the primary endpoint. And they also did not necessarily include all patients with diabetes, so you have to take a subset of these studies to actually look at the cohort that had type 2 diabetes. There's limitations with that. And consequently, sample size is often not significant to have the power to show a difference, even small but clinically significant differences. So then the other thing is that these trials differ in the severity of diabetes, okay? You're going to see much better changes or improvements in diabetes in patients who have milder disease. So STAMPEDE, for example, had fairly advanced diabetes. So did the sleeve pass study. But SM-BOSS and the Ruiz-Tovar study had fairly mild diabetes. So you have to consider that when you look at these evaluations. So based on these studies, the differences were fairly inconclusive, and none of these were significant in terms of the p-value. But again, you can argue that they were really underpowered. Now, what about the recent follow-up of the sleeve pass study by Paulina Salmini? A really wonderful study. All of you should read that. 85% follow-up at 10 years. It was just published last year. And here's some of the key take-home messages. There was a clear benefit in terms of weight loss favoring the bypass over sleeve, 43% excess weight loss versus 50% for the bypass. Remission was higher for the bypass, but again, not statistically significant, probably because of a sample size issue. And a relatively small percent of the patients, 25 to 30%, actually had diabetes in the study. The bypass was superior in terms of remission of hypertension, which is a very important risk factor for cardiovascular disease. Gastric bypass was also superior in terms of GERD control. Patients had a third less GERD with bypass compared to sleeve, and this is nothing new to this audience. And the reoperation rates were similar. And interesting, if you drill down, and I'll just focus on their complication profile in that study a bit, the overall minor and major complications at 10 years were quite comparable. In fact, it was a little bit less for the bypass, 29% versus 42% for the sleeve. And when you look at major complications, they were fairly similar. And one of the differences is that there was a high reoperation rate for GERD in the sleeve group. And there was a high reoperation rate for internal hernias. They had a much higher rate of internal hernias, well over 10%, which is much higher than you see in most other studies. And they did admit that they did not routinely close those mesenteric defects in the study, which is probably the reason why they had such a high internal hernia rate. But if you delete or if you reduce that internal hernia rate down to what you see with other studies, this study shows that the long-term major complication rate is actually lower for the bypass than sleeve gastrectomy. And this is probably the best 10-year randomized trial we have. Now, just a few weeks ago, a randomized controlled trial that was specifically targeted for diabetes was published. And this is the only triple-blind bariatric study that I've ever seen. Patients were blinded to the operation, not only the surgeons and the people managing the study. All these patients had diabetes, 3-year follow-up, And this study showed that the bypass was superior to the sleeve in terms of quality of life measurements, reflux, percent weight loss, and remission. And remission was over twice as good with the bypass for the sleeve. And this is a study that was designed with the appropriate sample size to actually look at remission and glycemic control. Now, everything I've told you so far are just surrogate markers of disease. The most important thing is the long-term outcomes, cardiovascular endpoints. Now, Dr. Morton talked about the Ted Adams study, and John, I'm glad you brought that up. I think they reported just the mortality, and it's a bit hard to put that together, isn't it, John? When they showed that the bypass causes better weight loss, but yet the sleeve actually had better long-term. But let's look at another study. This is a study from Cleveland, where we had a fairly large sample, over 11,000 in the control group, over 1,000 gastric bypass, and 700 sleeve gastrectomy. All these people had diabetes. If you look at 6-component MACE, which is heart attack, stroke, death, heart failure, atrial fibrillation, and neuropathy, you see that clearly the gastric bypass had a lower rate of a 6-component MACE and 3-component MACE, which is the 3 biggies, heart attack, stroke, and death. And this, again, observational study. And then if you look specifically at the components, all-cause mortality, heart failure, coronary artery disease, a big difference there with coronary artery disease, and atrial fibrillation, they all tended to favor gastric bypass versus sleeve gastrectomy. And that's the most important endpoint. Not so much the A1C, the amount of weight loss, but 5-10 years later, who's alive, who's dead, and those who are alive, who's had strokes or heart attacks and who hasn't. Now, to help you out, this was published a few years ago. We published in Annals. This was a series of almost 1,000 patients who had at least 5-year follow-up after gastric bypass. These patients had diabetes. And you compare sleeve and bypass. If you can break them into mild, moderate, and severe diabetes disease, that's going to help you sort out who should get one operation. If it's mild disease, both operations are fairly good at remission. Remission rates in the 80-90% rate. Now, moderate disease, this is where the bypass really separates. With the bypass, you see remission rates in the 60-70% versus sleeve like in the 30 to 40% range. And then when they have very advanced disease, both these procedures rarely cause remission with advanced disease. Remission rates are about 10% for advanced disease. So that can help you sort that out. We actually put together an app. It's a free app that Dr. Aminian actually put together and the team at Cleveland Clinic. You can get it online. You can just download it. And basically all you need to do is punch in some key parameters. How long has your patient had diabetes? What diabetes medications are they on? Are they on insulin? You punch those in and what their current control is prior to surgery, and it'll tell you which operation is probably the best option for your patient. That's one of several decision-making apps out there that help you. So in conclusion, based on the data, evidence, for diabetes specifically, fairly mild disease, I think the bypass or the sleeve are probably comparable in terms of remission rates. Although, based on the MACE outcome data, the bypass probably has an edge there. Moderate disease, I think the bypass clearly has an edge. And more severe disease, which is also accompanied by usually a higher operative risk, this is where you may want to go with the slightly less risky operation, the sleeve gastrectomy. Then there's other subsets. For young people, I prefer the bypass because they have so many years of life exposed to the risks of diabetes. Obviously, if they have GERD, I think bypass is a better option. And those, as John Morton pointed out, higher BMI, 50 and above, the bypass is probably the better option for those folks. They stand a better chance of getting to a good overall body mass index. So I think I'll stop there. Thank you all for your attention. Look forward to the questions. Yeah.
Thank you very much, Phil. Great summary of the evidence. It's a pleasure for me to introduce the next speaker, not only because, for those who don't know, he has been my mentor, Dr. Michel Gagné. But and maybe he's not proud of that, but I'm proud of him. And I want to say that it's also a pleasure because we will challenge Dr. Gagné, who you know is a pioneer, is the pioneer of sleeve gastrectomy, to tell us when sleeve gastrectomy perhaps is not the ideal choice.
Well, that's easy. It's no.
Done it.
Now, there are three things that the gastric bypass surgeons have a very severe negation. And that is one, the ultimate thing is mortality long-term. And there's more and more evidence showing that in long-term, the mortality is less with sleeve than with gastric bypass. So does it matter about reflux, weight loss, this and that? But if you live longer, that's what matters to patients. And that's why they often choose this operation. Now, Corculus in your city has demonstrated there was a 50% less mortality with sleeve than with gastric bypass. Nobody believed it. Then the Kaiser Permanente published their data on 100,000 patients in JAMA surgery just a year and a half ago. There was 35% less mortality long-term, more than 5 years, up to 10 years, with sleeve versus gastric bypass. And now we have heard Dr. Morton with a third study showing the same thing, that mortality was less. So that's first negation, you know. The second negation about type 2 diabetes is that Roux-en-Y gastric bypass is not the best operation. So we can compare two operations, but there's one outside this room, and that is another group of operation that is better than type 2 diabetes. So are you telling your patient the best operation for type 2 diabetes? If you're not doing a service to them. The third one is that sleeve is not a finality. They keep telling sleeve versus bypass as if sleeve was there forever. It's not there forever. It's the first stage of two-stage operation. So you have the choice. You have an obligation to do a second stage if the patient is not doing well. Yet in those studies, they keep the patient with the sleeve forever to demonstrate that the sleeve may not be as good. Well, these are the three sins, in my opinion, that we should be discussing. So these are my disclosures. And if we look at some of the 10-year data in PubMed out there, we have the sleeve pass from Finland. And when you look at the curve, they're really, really similar on weight loss. There's a small statistical difference, and that's 8.4% of difference at 10 years, 3.5 of body mass index. It is true that they operated more for reflux, but in my opinion, 10% for reflux is very high. So I'll give you the same argument for your internal hernia. I would say operating for reflux is very high because drugs are working well. And there's no difference on Barrett's. Okay, there's reflux, but there was no difference in Barrett's, 4% in each group at 10 years. So it's going to be dangerous for cancer. Not true. And if I go back in the two 10-year study, Professor Peterli, Professor Salminem, they had mortality in their initial papers, but in the last papers at 10 years, mortality has disappeared. Again, to make the point that mortality was higher in Roux-en-Y gastric bypass groups than in sleeve gastrectomy. So the incidence of reflux, GERD, and carcinoma, this is often an argument for saying, don't do sleeve. It progresses, whatever the operation is. Esophagitis, Barrett's esophagus, and carcinoma, no difference also. Now let's look at Lazati operation paper on esophageal and gastric cancer after bariatric surgery. They compare this to control who were not operating. Bariatric surgery was causing or having less esophageal cancer and gastric cancer, but when they look at the breakdown of the different operations, listen, there was no difference either. So stop saying sleeve is causing esophageal cancer. So here's the long-term systematic review from Australia, looking at the different operation at 10 years. They did not see much difference in the weighted means of percentage of excess weight loss between the different operations. So maybe the patient's behaving with long-term no matter what. What's interesting is if you do the sleeve in very young patients, it is sustained over time. If we look at 9-year study and I know well this team from Qatar, the BMI change has not changed from year 1 to year 9. 38% total body weight loss at 9 years. And if we look at the hemoglobin A1C, fasting blood glucose, it was sustained. Now, there was a small cohort that went revisional surgery, and the revisional surgery was not for type 2 diabetes, but was for mainly weight regain. And in the choices of operation, it wasn't Roux-en-Y gastric bypass, it was mainly hypoabsorptive surgery. Now, another one from Saudi, looking at young patients, again, very large cohort. This is more than several hundreds of patients, and you can see that at 10 years, it is a sustained, again, good weight loss at more than 10 years with very low morbidity. Again, this series at 10 years of young adults, adolescent patients, 10 years, they sustained their weight loss at that time. If you look at the 10-year data, the body mass index is 30. It started at 49, was 28 at 3.5 years, and 30. So very good result at 10 years with young patients. And Dr. Peterli, who's there in the front, has looked at 10-year data, and if it is intention to treat analysis with the sleeve, that is, if you do a second stage at one point, the weight loss is not any different at 10 years with Roux-en-Y gastric bypass. 10 years outcome, again, in this monocentric study, was not as good. So there are surgical differences between groups and surgeons, in my opinion. Sleeve needs to be done with certain technical aspects that are important. That's why if I compare my first 100 gastric bypass that I started in 1995 at the Cleveland Clinic, and one of the fellows here, Dr. Takeshi Nato, and Dr. Rubino came a few years later. If I compare my first gastric bypass with and look at the 10, 25 year data, it's going to be bad because the operation has changed. And what we know is that body mass index more than 50, and the results at 1 year will give you lesser good results. So this is a cohort that we have to pay attention, that sleeve alone on body mass index more than 50 is certainly not the message we should tell our patients. They should have a 2-stage procedure. So if you put them in a randomized control trial and you leave them with a failed sleeve, it's not honest, in my opinion. In this comparison between sleeve and bending, the 10-year data was fairly identical between the two groups, fairly sustained weight loss at 10 years. In this meta-analysis of randomized control trial, it was favoring a little bit Roux-en-Y gastric bypass for weight loss. I give that to Phil. The difference was not very big, but when I looked at type 2 diabetes, there was no difference between the groups in this meta-analysis. 10 years result, and again in a retrospective single study, another one showing not much difference at 10 years, and I think that that was sustained in this analysis. Same message. I'm just going to skip that because I want to put some emphasis on something else, that in this series at 10 years, there was resolution of type 2 diabetes of 72%, so that was pretty good. And if you look at hypertension, 52%, hyperlipidemia, 58%. We know that there's reoperation in sleeve gastrectomy. This is the national cohort data from France, and it increases about 1% per year. And those that have revision, there's more females than males. Body mass index more than 50, that's again a key point. Previous history of gastric bending, because they did a lot of bending in France. And there was, of course, the type 2 diabetes. But the problem is they did mostly Roux-en-Y gastric bypass on these patients, and I think that was really the wrong operation, especially for weight gain and for type 2 diabetes, in my opinion. For reflux was only 5% of the overall total cohort. So that's 0.5% over a period of 10 years. When I see the Finnish doing 10, 12, 13% of revision for Roux-en-Y gastric for reflux, then I'm wondering, is this really correct? Maybe it is dependent on the surgeon and not so much on the patient. The French problem, the French study in this national cohort is they don't count the two-stage procedure. It goes into a revision. When you see a patient with a body mass index more than 50 and you say, I'm going to do a sleeve, and 2 years later I'm going to do another operation because I staged them, in the data it counts as a revision. It's not a revision, it's a planned two-stage, and we don't know how many are planned two stages. For weight regain after sleeve, this meta-analysis again shows that SADI, the group of hypoabsorptive surgery, is much better than Roux-en-Y gastric bypass. So you're selecting the wrong operation for weight regain when you decide to go for a Roux-en-Y gastric bypass. I tell the patient it's like changing $1 for 4 quarters. You're not going to get really superior result, in my opinion. And the morbidity favors slightly Roux-en-Y gastric bypass, but that difference was almost insignificant. Now, as I said, one of the third sin of the Roux-en-Y gastric bypass surgeon was the fact that they did not look for type 2 diabetes at the right operation. The chair did a good study and demonstrated that hypoabsorptive surgery was dramatically better for type 2 diabetes. It was, at 5 years, 63% complete remission versus 37%. Now, looking at that at 10 years, it was 25% with the Roux-en-Y gastric bypass versus 50% for hypoabsorptive surgery. So why would you tell your patient, I'm going to do an operation for type 2 diabetes, but you only have 1 chance out of 4 to be in remission for type 2 diabetes 10 years down the road? Plus, the mortality is going to be 35% to 50% higher if you choose gastric bypass versus sleeve. With the sleeve, if you do well with for type 2 diabetes, you don't need more. But if you don't do as well, you can get a second chance with hypoabsorptive surgery, and that hypoabsorptive surgery should not be Roux-en-Y gastric bypass. It should be SADI or something similar. So if we look at University of Laval, Quebec City, long-term, 25, 30%, 30 years data on type 2 diabetes, this remission is 87% in this group. So, Mr. Chairman, I'm going to finish on time and summarize that sleeve gastrectomy at 10 years, you should be proud of this data. And it's much better on younger patients. You should operate on them younger, because those 10 years data is a straight line for young patients, young adults, and adolescents. We have poorer result with body mass index more than 50, and you should tell these patients they will require a second operation. Expect a second operation. Barrett's esophagus and esophageal cancer is not any different than Roux-en-Y gastric bypass, and in fact, it is lower than controls. And most studies, as I said, randomized control study, failed the multi-stage of the sleeve. That's important. We have options to revise. How are you going to revise someone that now has a type 2 diabetes and has a Roux-en-Y? How are you going to improve that? Can I have my last slide? Okay. When not to do a sleeve. When retatrutide is approved, because that's what we're going to do. We're going to put patients on drugs, and maybe we're going to do a sleeve. If we do surgery, they should not get intestinal surgery. They should get gastric surgery. Body mass more than 50. If it's not planned as a 2-stage, they should not get a sleeve because they will not be happy. Barrett's esophagus, I say that because if they progress, they're going to need the stomach to replace the lower esophagus. So you don't want to destroy the stomach for a potential esophageal operation. And if the patient is not a candidate for hypoabsorptive surgery after that, then don't offer them to have a sleeve. Thank you.
Thank you very much. You know, as a chair, I have to stay above the fray, and as a, you know, you're my former mentor, I cannot argue with you, but I would argue, but I'd like the panel discussant to do that. The next speaker is my friend, Dr. Ricardo Cohen from Brazil, who will tell instead when not to do a gastric bypass, and I hope you tell us when not to do a gastric bypass.
I will tell you. I'll tell you, because I thought I slept in Michel's lecture because I didn't see when he does a gastric bypass, but I probably slept. Can I have the first slide, please? I think the sleeve fanatics have some sins as well. First, they think that adding an operation, it's like adding a drug. So it's not adding metformin and then I add TZDs and then I add GLP-1 receptor analogs. So that's not the same. Revising a patient is not the same. Do the fanatics tell the patients, you have a 40% chance of reoperation? No, they don't, because the sleeve, in their mind, is great. The second sin of the malabsorptive procedure is a victory of Pirro. You know the victory of Pirro? 5 soldiers defeated 10,000 soldiers. But the one that remained at Pirro, he died because there were more 50,000 soldiers against 1. So it's a Victoria de Pirro. So malabsorption is a Victoria de Pirro. Sin number 2. Not all, but most of the data of the fanatics on a gastric sleeve are based on retrospective or prospective studies. If we look at the randomized control trials, first, there's no safety issues between them. The sleeve is not less dangerous than a bypass in level 1 evidence. If you go to retrospective studies, they're very biased because there's a selection bias. So patients, sicker patients, heavier patients will have a gastric bypass and not a sleeve. And Michel, the perfect sleeve is a gastric bypass. So the perfect sleeve is don't do it. Those are my disclosures. And then I start looking at the data because, yes, I'm going to show when I do a sleeve. I do sometimes. First, look at that. 50% conversion of sleeves due to insufficient weight loss or weight regain. Look at this data. They concluded that at 10 years, the sleeve is an adjustable gastric banding. The same outcomes at 10 years. And I'm using the studies that the fanatics love. They love retrospective and prospective studies. If you look at Salmina Paulina, we can see that, I think Phil showed, everybody showed already, that the bypass has better long-term weight loss. And if you look at quality of life and disease-specific quality of life, the bypass wins again, and this is level 1 evidence. If you look at the Olsenberg trial that Phil alluded to, it's interesting that at 10 and at 3 years, and I wonder, you said, Phil, that's a triple blind. No, the surgeons were not blind, otherwise they would kill the patients. So we can see here weight loss at 3 years, there's no comparison. Type 2 diabetes remission, again, there's no comparison. Then The slides are not changing. Can I have the next slide, please? If you look at the bi-band sleeve, I'm sorry for the slides because it was taken during the presentation at the British meeting. Look at total body weight loss in this randomized control trial. Favors the bypass. Look at quality of life. Favors the good and old bypass. If you look at incremental monetary benefits, again, it's the gastric bypass. So it's not a personal opinion, it's data. This is a randomized controlled trial. It's not retrospective, it's not match paired, it's not prospective. If you look at the medication use regarding sleeve versus gastric bypass in almost 100,000 patients. Again, the bypass, the slides are not moving again. Michelle, stop doing this. Patients with the bypass has a greater withdrawal on anti-diabetes medications, blood pressure, statins, and again, it's not changing, and less anti-type 2 diabetes, blood pressures, and statins after withdrawing them at 5 years. Again, favoring the gastric bypass. And this is very interesting data. If you look at patients without nephropathy at baseline, without no kidney disease, and you look at that 5 years, look at the numbers. There's much less, significantly less nephropathy in the gastric bypass patients when compared to the sleeve. So again, favoring the sleeve. And chronic kidney disease is a proxy of mortality. Patients with diabetes, obesity, and chronic kidney disease die 10 times more than patients with diabetes, obesity, and no kidney disease. So microvascular complications are very important risk factors. So I started to think, when should I do a sleeve? And I thought, and I said, to my enemies. I think I should do a sleeve to my enemies because I see no advantages of doing this. So if I don't like anybody, say, okay, come, I'll do a sleeve because you'll do well. But then I said, well, Francesco asked me to speak about this. So he's my friend. I know him for 25 years. I need to think about this. So I thought, and this is when I do a sleeve. And this is honest. This is when I do real sleeve. It's 5%, if so, in my practice of 700 patients a year. So first, hypoparathyroidism and hypocalcemia, when I need the duodenum to absorb calcium. So anecdotally, we did 2 this year. That's too much. 2 sleeves because of this. That's weird because it was a surgical parathyroidectomy and another was, I think, an autoimmune parathyroiditis. So this is the first example of when I do a sleeve. The other, active Crohn's disease. But if you look at the literature, it's controversial. There's some groups that do a bypass with remission of the Crohn's disease. But again, a small series, I don't think that's science. So in active Crohn's disease, I would do a sleeve. Previous multiple abdominal operations. When patients present like this is a real patient, I would do a sleeve because I wouldn't put my patients into a surgical risk. In my hospital, we work with a prominent abdominal wall surgeon, that's Sergio Roll, and we do a lot of things together. So lots of abdominal hernias that need weight loss, and they do not respond to GLP-1 receptor analogs or twin incretins like tirzepatide. We try to do a bypass. If we can't, we mostly cannot, we do a sleeve gastrectomy. Heavy smokers. Heavy smokers are a good indication for a gastric sleeve. Portal hypertension, it's controversial as well. There are results saying that sleeve is safer, others they say that bypass is safer. So in our practice, without any evidence based on feeling, I would do a sleeve gastrectomy. Kidney transplantation, we're running a randomized control trial on end-stage kidney disease. So we went after what happens to the immunosuppressants. Nothing. There's no malabsorption of immunosuppressants after a bypass. In a bypass, we have to take care of oxaluria. Oxaluria is a problem to the graft, but you have to screen it with urinary levels of magnesium. If it goes up, call the nephrologist and they should treat it. But regarding the absorption of immunosuppressants, there's no difference between them. Liver transplantation, there's very low evidence that the sleeve is better after the liver transplantation. That's mixed info in the literature. However, when you perform a transplant and a bariatric intervention during the transplantation, the sleeve has better outcomes. So I've never done one, but I've done a bypass in a patient during a liver transplantation, but literature shows that probably the sleeve would be a better option. Atrophic gastritis, but I can always take the remnant out, so I've not been doing sleeve gastrectomies in atrophic gastritis, but we can do it. It's a reasonable option. Gastric familial polyposis is a theoretical indications for a sleeve gastrectomy because you need endoscopic surveillance. The need for easy endoscopic access to the vater papilla, like duodenal adenomas, submucosal lesions that may need surveillance, it's a good option to perform a sleeve. Eventually, drugs that may need the stomach to be absorbed, there are some experimental new cancer drugs. We did a case recently in a patient that was into a protocol for a new, I don't remember the drug, the name of the drug, but it needed a stomach, so we did a sleeve gastrectomy. Chronic use of NSAIDs, it's an indication, although I don't remember any situation that anti-inflammatory non-steroidal drugs should be taken forever, but it may be a good option for a sleeve. And if you look at diabetes, we know today that diabetes is not only one disease. We have different clusters. And I'm gonna focus on the severe insulin deficient diabetes. The severe insulin deficient diabetes had lower rates of glycemic remission when compared to the insulin resistant, it's wrong there, insulin resistant patients. So if you have an insulin deficient patient, an insulinopenic patient, they don't have good glycemic control, worse than the insulin resistant, and they do not downgrade the chronic kidney disease state, and they decrease their eGFR. So if you have a patient that insulinopenic diabetes in its cluster, but he needs weight loss for other reasons like joint problems, mobility problems, whatever, probably the sleeve will be a good option, like Phil showed in the Cleveland Clinic calculator. In summary, the rule is the gastric bypass. When should we do a sleeve? Persons with hypoparathyroidism, hypocalcemia, active Crohn's disease, multiple previous operations, abdominal hernias with loss of domain, heavy smokers or users of anti-inflammatory, non-steroidal anti-inflammatories, the severe insulinopenic cluster, but with other comorbidities that will need weight loss, gastric familial polyposis, or the need for the papilla surveillance. Thank you very much.
Thank you. I think that all the speakers were very convincing, and I think we must have a boxing ring for them for the discussion. But now we have a panel of experts for the discussion, and I see here Dr. Peterle, and I want to ask him if he want to make some comments about the talks we heard.
Thank you very much. I really have to congratulate all the speakers for really good and comprehensive talks, and they're also funny. I have one remark. We should not cite Ruiz Tovar anymore, because really take them out of all the meta-analysis, because his papers had to be retracted because it was fraud. So I think we have to take him out. And the second is, I have to give point to Michel that usually the second stage, I mean, that is the concept of the sleeve. So this does mix up the statistics a lot, because you have to have a second stage. But I disagree that you can always add hypoabsorption and bypass in a very easy way, so that both are good. And I think The IMS score in the merged data we had for the sleeve pass and the SM-BOSS trial, it did not work. So I think we do need tools. I think these clusters are very important where we can allocate some of the operations and the treatments. But I think we are happy to have both operations.
Let's fight a little bit more than I think you made the right point. First of all, again, the paper of the being retracted, the author you mentioned, is very important that people are aware, because otherwise we keep citing wrong literature and we can confuse evidence. Yes, there's a question. Let's go with that.
Yes. My name is Willy Våge. I'm the leader of the Norwegian Registry for Bariatric Surgery. I'd like to congratulate the presentations, and I want to specifically address the three who presented. First, John, congratulations. You were making philosophies whether Roux-en-Y gastric bypass had a weight loss independent mechanism, and you were showing data at 1 year follow-up. And we know that at 1 year, you have not reached weight stability, and there's a lot of things going on with the gut peptides and so on. Actually, this was looked upon in the SOS study with 2-year follow-up. And they found that if you compare the Roux-en-Y gastric bypass with the restrictive method, at the time it was VBG and gastric banding. But if you compared the remission rate according to weight loss outcome, it was exactly the same remission rate if you had the same weight loss. So that tells me if you have the same weight loss with the sleeve, you'll have the same remission rate as with the Roux-en-Y gastric bypass. And then, Phil Schauer, you cited a study from Norway that came out this summer in the Lancet Diabetes and Endocrinology. And this, when you have good quality registers with a high capture rate and good follow-up, we can follow all the hospitals. I must say that this hospital was notified by the National Advisory Board 2 years ago because they have low weight loss outcome, much lower weight loss outcome than any other Norwegian hospital. So it's a weight loss performance, their performance outliers. And I brought this up to the National Board again when this study came up. What should we do now? So the National Advisory Board is discussing it, but it's kind of being a performance outlier. You're being applauded for having done a randomized trial instead of being scrutinized for having low weight loss. Because if this study had been carried out in any other hospital in Norway, our statistician looked at that. If it had been carried out in any other hospital in Norway, the remission rate would have been the same. Thank you.
Okay. All right. Why don't we do this? I said I wouldn't pick up a fight with Michelle, and I will not. But I can't refrain from picking on a couple of things you said. And rather than asking you or Ricardo, who already have given your opinion, I will ask Phil and John and Ralph if you could comment on this concept of the 2 stages operations and also the operator-dependent issues that Michelle alluded to for sleeve gastrectomy. So if we have to say that sleeve requires another operation, if we have to say that bad outcomes of sleeve will depend on the operator, we don't have Michel Gagnets everywhere in the world, we have surgeons. If a pill has to be the same thing in any place in the world, so if an operation is not able to be the same around the world, wouldn't be that a limitation of that operation? And if you have to plan a second operation and additional costs, wouldn't be that a limitation of an operation as opposed to a merit of an operation? So can you, the 3 of you, comment on that?
Well, I think the point about standardizing surgeries is critical, and we don't have a standard dose of surgery, and there is a lot of variation when it comes to the sleeve. You know, when you look at outcomes, there's the hockey stick, where, you know, you've got an extra fundus, or you have a dumbbell where it's too close, or you have a Christmas tree. That being said, there is ways of standardizing it. There's actually new technology. You know, there's the Titan stapler that will give you the straight line. But there's ways that you can teach this. But we should also mention there are not uniform ways of doing a DS. There's not uniform ways of doing a gastric bypass either. So I think all those things come into play. I got to admit that Michelle told me about, I don't know, 10 years ago that we should always do sleeves first, because then you can figure it out. And I thought, nah, no way, you know, I'm a bypass guy, I love the bypass. But I got to say, he's opened up my eyes about the sleeve, and some of the emerging data that's coming out looks interesting. The one point of contention I would have is that as the conversion for the sleeves, most of the time the ones I'm converting are due to reflux, and I actually think the bypass is better for them. And those are the ones that I prefer to convert. The DES is a powerful operation, but it can have risk. That same Adams study showed it actually had no survival benefit, that patients died more often with the DS than they did without it. So it's something we have to keep in mind. I think you hit the nail on the head. If it's done perfectly, it goes great. But if it's not done well, it can go poorly. Thanks.
Yeah, I'll just add, with the malabsorption operations, and Michelle had hypoabsorption operation, I should say. Michelle brought, no one's debating that a BPD is not superior to a gastric bypass if you look just purely at glycemic control. There's no debate there. But when we're talking to patients and discussing procedure selection, it's always a risk-benefit. It's always a risk-benefit. And what Michelle didn't show, Professor Rubino's study, with a sample size of just 20 patients at 5 years, there was a very high percent of patients that had metabolic bone disease, that had protein-calorie malnutrition, even in a sample of 20. You know, and if you look at the people who are the best in the world at doing that operation, and I'm an advocate for, in some patients, there is still a significant rate of long-term nutritional issues.
That's the Pyrrhic victory.
Right, right. And John, it's not how well the surgeon performs the procedure. Many times it's the follow-up, it's patient adherence to the nutrients, and it's the patient's own ability to absorb the nutrients, yeah. But let me just call, you know, this debate about these operations. You can pick so many different studies, you know, but as Ricardo, I think, appropriately pointed out, that's the value of a randomized controlled trial, okay? The procedures are standardized, and those randomized controlled trials, you can look at how they perform the sleeve. They document how they do it. It's usually the same surgeon or group of surgeons, you know, compared to these multi-center retrospective studies. You can argue, you know, what is the quality of the surgery, but in a randomized trial, it's usually well-defined procedures, and most importantly, patients are matched. Because we all know that there are many factors that may address weight loss. The gentleman talked about, and I think it's inappropriate to criticize another center without that center being able to defend themselves, excuse me. But there are many factors that explain why one center has lower weight loss than another. Perhaps they have more patients with diabetes in their study. Perhaps they have different ethnic groups. We know those are the many factors that will lower weight loss. And how do you know what that center has in their population? Lower social determinants of health are probably more important than most of the things that we consider today that may affect weight loss or any outcome. So again, that's why these randomized controlled trials are the ones that help us sort out all of the murky variables and hone it down to you know, one or two key endpoints to look at when you're comparing interventions. And that's what we have to go by. Thank you.
I disagree with these small, selected, randomized control trial, because what matters is real life, is what's happening out there in hundreds and thousands of patients. Now, your first slide, Phil, was MBS QIP data. And mortality, operative mortality, was shown on this slide, was 0.2 for bypass and 0.1 for sleeve. The operative mortality was twice as much. Now, if you survive the operation, you were still dying more over time with Roux-en-Y gastric bypass. So this is real life data. You're not going to get mortality data from 50 patients, 100 patients. You're not going to get operative mortality, but you're going to get it in real life data. That's why I think it is important. The insurance is looking at this because they are the payers. If you look at Kaiser Permanente, they will tell you you're dying more with a bypass than with a sleeve gastrectomy. So that's important data, in my opinion. Now, the Pyrrhic victory is that you're going to be alive more with sleeve than with gastric bypass in real life data. The BPD, I agree with you, is not something we should be doing. That's why we showed Laval's data in duodenal switch, and even duodenal switch has been improved with single anastomosis SADI, duodenal ileostomy, and there are even more better ones that are coming, hypoabsorptive surgery. So those ones cause resolution of type 2 diabetes in a much better way than Roux-en-Y gastric bypass. Why would you give an operation that gives only 25% resolution at 10 years? Why? And then the patient is stuck.
You have to criticize the number of remission you use on RCT. Yeah? You criticize the bypass comparing to the BPD used in RCT, but you value real-world data that is completely mixed, is biased, is not well collected sometimes. So we need to think, to be balanced, to use the RCTs in the proper way for the best outcomes for our patients. And this is what you have to do, evidence-based metabolic surgery. Ralph?
Well, I'm really a fan of RCTs, but there are drawbacks. I mean, this Norwegian trial was totally underpowered. I mean, how many cases were they?
Which one?
The Norwegian trial, there were below 100 patients, diabetic patients, and they had a remission rate as primary endpoint. I mean, I don't know how Lancet accepted that paper. I mean, it's not scientifically properly done. I'm sorry. A sleeve pass and SM-BOSS were underpowered for this endpoint. So I think you need randomized trials, but other safety issues sometimes come from big registries.
The sleeve pass and the SM-BOSS had weight loss as a primary endpoint.
I know. No.
The Oserberg trial had diabetes remission as a primary endpoint. So, and it's powerful. I was one of the reviewers. It's powerful then.
No, but what I'm trying to say is, you always have a primary endpoint that you can reach, but then you still make comments or present results on your secondary ones where you're not powered, where you're underpowered.
Exactly.
Yeah.
The SM-BOSS and the sleeve test were not powered for diabetes remission. The Oserberg trial was powered for diabetes remission.
With 60 patients? How would you do that?
Yeah, with 60 patients. Well, he had 60 patients in 3 arms, and it was powered to detect difference between the medical and the surgical arm.
But then I go back to your first question. I mean, it's not the technique. I mean, we standardized in that randomized trial. The techniques were very standardized, and if you look at our spaghetti plots, the biology is totally different in these patients. So you cannot blame that you have a variety of results and blame that it's not done properly. I think it is the biology. We treat different patients. And the last comment I want to make, if you do, and there are certain patients, they need hypoabsorption, and usually they have higher BMI, but not only them. And if they do have hypoabsorption, you're only allowed to do that if you have an extremely good follow-up, because they do have side effects which are important, which will contribute to some deaths maybe, so these come in the statistics, but if you do control them properly, it's a very efficient operation with a 95% remission rate of diabetes.
Just one extra topic so that we can put things in context. We're living today in a different environment than we were even just 5 years ago, and 5 years from now will be even different. So we're going to deal with medications that are increasingly effective at weight loss. Also good, they give good diabetes control, but perhaps they're still not as good as surgery at reducing overall cardiometabolic risk or preventing hard endpoints. We don't have randomized trials for those yet, but the problem is those will be our comparator. In this context, can we still see metabolic surgery in 5 years from now debating 2 procedures with surgical preference as opposed to having a proper randomized trials-based, evidence-based assessment as people do for medications. Because if you want to beat the medications, you have to beat them at their own game. Otherwise, people will not think that surgery is credible. How do you envision the future of surgery in the context of now being challenged by medications even for obesity, not just for diabetes?
Yeah. And that's one thing that we're missing in our field. And I'll agree with Michelle in that one of the big limitations of the randomized trials we have so far is they're only powered for surrogate markers of disease. They're powered for weight loss, they're powered for blood pressure, they're powered for glycemic control. What really matters is, cardiovascular events, cancer, major morbidity and mortality. And the study I showed you at Cleveland Clinic, it was the data, I'm pretty sure it's pretty good data because our cardiologist reviewed it with us. It's the only data presented today that shows that the bypass was superior to the sleeve in terms of reduction in cardiovascular mortality, heart attack, stroke, death, atrial fibrillation, and heart failure. It's the only data presented today. But even with that, it's imperfect. And so my plea, and what I've been trying to do for the last 10, 15, 20 years, is to get the funding to do a proper, large, multi-center randomized controlled trial where we have 2,000, 3,000 patients, where we compare perhaps the two most common operations, bypass and sleeve, with medical therapy for patients with obesity and diabetes. That's what we need. They're expensive to do, they're hard to do, but
it's an ongoing trial right now.
Yes.
Yeah.
Yeah, that's what we need. But, the SELECT trial, it cost $1 billion, but they had the money. Pharma has those deep pockets. But who's going to fund a large surgical trial? Pharma is not going to put any money into it, that's for sure. And even agencies like the NIH and big government agencies have so far not been willing to put the money in for those trials.
Francesco, you've raised a very critical point, which is what will the future be? We now have new therapy that's very powerful, and at some point or another, there will be a head-to-head. We have to figure out our way for the future, and I think the one thing that we have to do is collaborate. We have to work with those anti-obesity medicine specialists. At Yale, we keep them all under one roof, and the service line, the financials are all integrated because they currently don't make money, for the hospital or for their clinic. And we have built into our model that there be a 20% referral rate at some point or another. That's based on historical trends. 20% of those patients ended up in surgery after 3 years. And if you look at the data, half of the patients aren't still on medication at the end of 1 year, and then about 20% can't tolerate it. That being said, it will be part of the landscape. And we have to figure out how this works. We have to maybe take a page from the oncologist and use these medications like chemotherapy, neoadjuvant for the difficult patient, BMI greater than 50, rescue therapy when patients don't lose enough weight. And we know they're not going to lose enough weight as early as 3 months, and you can initiate therapy at that point. Where is our tamoxifen? You have your breast cancer surgeons, they use tamoxifen to ensure and safeguard the great results we have for bariatric surgery. I don't think the sleeve's going to go away. I do think there is obviously a role for the bypass for many of our patients. It's a terrific anti-reflux procedure. I think the SADI will have a role, but I don't think it's going to grow as much as we think. I think that it's unfortunate that there will be some new medications that will blunt that effect. We will end up seeing, at the end of the day, 5 years from now, sicker, heavier patients, and we have to recognize that and be prepared for it. And I don't think there's any operation that's going to hit all the points. Are you going to get diabetes remission? You can get quality of life, or you can get survival benefit. You have to tailor it to the patient, precision medicine.
Yeah, just going to comment on the medications. I mean, Lilly says they're not going to sponsor any head-to-head trial with surgery. I mean, how can we do these trials if they block it? I'm very sad about that because I want to do one with NASH, but they said no. And the second thing is, I'm not afraid of these drugs. As you said, I mean, we use them neoadjuvant, adjuvant. It's kind of multimodal concepts, and if you work like in an interdisciplinary team, I worked with that for many, many years, more than 20 years, and it works. And then the patient gets what they need. And for the procedure choice, they will both exist, but if the patient is well informed about the side effects and the drawbacks, if he has a sleeve, he has a higher risk to have to go for conversion. If he knows that and he accepts the operation, then he will bear the risk and he will not complain about it. But if he knows he may have an internal hernia after a bypass, then he lives with it. I mean, there's no way you can 100% be sure that you're not going to have a higher internal hernia. So I think it's also a matter of how you inform your patient, but let them decide after they have been well informed.
Yes, the future is already here. There are countries and practices where the numbers are down by 10%, 15%, 20%, because the drugs are already here and they're given to patients. And if they fail drug 1, they have drug number 2. Then they fail drug number 2, they have drug number 3. So when are they going to send the patient for surgery? It's going to take time. And those physicians and patients have nothing to do with our debate today. You know, we're shooting ourselves in the foot. Oh, sleeve versus bypass. Oh, bypass versus... They don't want to hear this. They want to hear that they're not going to die from the operation and they can have the surgery with the least amount of problems. So, in my opinion, we're going to see more and more of the drugs, less and less of surgery, and if they choose surgery, it's going to be the least amount of surgery, because after surgery, they can still add drug 1 or 2 or 3. So it's going to be the least amount of surgery. We're shooting ourselves in the foot today.
For the past 100 years, I have to agree with Michel.
I think this is an important point, and regardless of where we stand on the debate of sleeve or bypass, I think we have to recognize that as a surgical community that the future may only look brighter for us if we change gear and also attitudes. When we have been doing this debate, sleeve versus bypass in the past, we have done it a little bit of almost like a show. You know, we have people who favor one thing or another, and we like this. We enjoy this type of things. We come to conferences and we like to hear Dr. Gagné against Dr. Cohen and Phil Shower coming and giving us another bypass view. But the thing is, this discussion will not help us, this kind of debate. We have to be against the reality that we need to go, like people, surgical or oncologic surgeons do, have protocols, make sure that we have protocols that include medical therapies when needed, adjuvant or neoadjuvant as they are, but make sure that we don't give the impression that we have, there is an operation, we don't even agree that there is an operation that's worth doing. Because once we present for one or another, very often we make the introduction by saying gastric bypass is not good. Stroke sleeve is not good. I mean, those operations, they're all good. So let's try to make sure that we stick to the evidence and maybe reduce in the future our, fun maybe in discussions, but increase our rigor on data and presentation so that we can challenge the rigor of the other drugs. I'd like to, Vincenzo, if you have any other consideration to make.
No, I don't have any other comments. I have a curiosity. I want to ask to Michel. You said that GERD is not a contraindication for sleeve gastrectomy, and I want to know, what do you think about the anti-reflux sleeve gastrectomies?
Yeah, this was not part of this debate. As you know, there are Nissen sleeve, partial Nissen sleeve, and what we don't know in randomized control trial, and maybe we need one if I agreed to do one, that would be for reflux patient, Roux-en-Y gastric bypass versus, let's say, Nissen sleeve, because we know from the Swedish data from Sahlgrenska Institute that if you do a bypass specifically on a reflux patient, 50% of them are back on medication 5 years later on PPI. So tell your patient, if you do this and they have reflux, that 1 out of 2 is not going to do well and going to be back on medicine. So perhaps a fundoplication with the sleeve might be a better operation for reflux. That's why I'm not totally excluding the sleeve for reflux patients.
Thank you. Back in disagreement.
Ricardo says he disagrees.
I'm back in disagreement. It didn't last so long.
It only lasted a second.
30 seconds.
30 seconds. However, the focus of this is diabetes. So Phil, you said, you proposed that people with mild or moderate diabetes would get bypass, and then when diabetes is severe, you see no difference in remission at that point, because diabetes is, way too difficult to control, and so at that point you say either one is fine. But should we only look at remission as an outcome? Or when you look at severe diabetes, you're not looking at just a severity of hyperglycemia. Severe diabetes means somebody has hypertension, liver disease, and so on and so forth. And do you think that, in that context, your recommendation still stands?
No, I agree. If you're just looking at remission in a person with advanced diabetes, 10 years into the diagnosis on insulin, you're not going to probably get remission with either procedure. But there could be other benefits that are driven by the weight loss. And I don't think there's any debate here. I think even Michelle agrees. Whether it's a randomized controlled trial or observational study, long-term data says you lose more weight with the bypass. But it comes at a price too. Usually those people with advanced diabetes also have many other comorbidities and are a higher operative risk as well. So you have to balance that risk-benefit out. The bypass may be a higher operative risk procedure, but may give better long-term weight loss. So trying to balance those risks out, yeah.
We ask John or Michelle, or whoever, last question probably, we have 5 minutes. So diabetes is a context where we came as surgeons with a new proposal, but was already a disease treated by medications. With obesity, we have the reverse. There was surgery, there were no medications, now we're going to get the medications in. Is there any lesson that you can see we can learn from diabetes in terms of how surgery relates to other medications, if it can make it in, and how this can be transported into obesity? What do you think really in the future will be the reason why you would recommend a medication, you, Michelle, maybe, as opposed to sleeve? And maybe you, Ricardo, can tell us when you would recommend a medication as opposed to bypass, this time not for diabetes, but for obesity.
I think in the new era of pharmacotherapy, if you have a patient with BMI 30 to 40 without metabolic comorbidities, drugs are the first option with a high chance of being very successful if the patient keeps on the medication, if they're adherent. So I think 30 to 40 without, and I think, and this is the Achilles heel of our IFSO ASMBS guidelines, because we are always challenged. Where's the literature on 35 to 40 without comorbidities when compared to drugs, for example? There's no data at all.
It's a critical point. We've done a lot of consensus about the surgery. Have we done consensus about obesity treatment?
No.
Not yet. We need to figure that out. Otherwise, it's just going to happen. I was going to make the exact point. If you look at the data for the drug trials, it's mid-30s is what they're doing. They don't have higher BMIs. So, I mean, what lessons can we learn? I mean, there's a lot of lessons that we can learn about what happened with bariatric surgery and obesity treatment. Mark Twain said one time, history doesn't repeat itself, but it sure does rhyme. So there's a lot of things that do occur over and over again. One thing, for the obesity, and you're seeing it right now with the medications, there's backlash about it. Wegovy face, that I'm having weird dreams, the cost involved with it. More people are having gastroparesis. Some of that is just, fake news at the end of the day. And we had to go through that as well to gain better acceptance. How did we gain better acceptance? Safety first. We had a legacy effect from the older operations where the mortality rate was 1%, now it's 0.1%. So I think safety is going to be important for them. They don't have a registry. They don't have a registry. All the stuff you've seen, like with Select and everything else, that's what the drug manufacturer, they need a registry of some sort. Within MBSA QIP, which we have 900 hospitals, we have a medical component. Now it has to be a hospital-based program, but they can collect data for that medical weight loss. But they need a registry as well, and they need to substantiate, that they've got some safety, there's no safety concerns with it. But we need a consensus about obesity treatment in general. Who goes first? How do we do it in combination? So maybe that will be the next conference. Really enjoyed it. Thank you.
Thank you. Phil, a very brief comment.
I was just going to, I totally endorse the concept that we should embrace the drugs. They're going to help our patients. But we also have to be a little cautious, too. there's no 5-year data on any drug, In the 20 to 30-year history of anti-obesity medication, there's never been a 5-year trial. It will be. We're going to see 5-year data. But is this 15% weight loss that we see at 1 or 2 years going to be what we see at 5 years? Well, if history is correct, almost every drug is going to lose, like surgery, is going to lose some efficacy over time. We're going to see that. And as John pointed out, the drugs so far have only been tested in lower BMI patients, mean BMI 35. We generally see patients much higher BMI. So if you can extrapolate the Manjaro with 20% weight loss, 20% weight loss in a patient with a BMI 55 is still going to leave them with severe obesity. So that's where I think the surgical procedures are really have a bigger play in these higher BMI patients. And I can tell you that there are many high BMI patients that are not seeing surgeons that really should be.
I'm old enough to have learned how to do gastrectomies for ulcers and vagotomy for ulcers. And even when I went to Nice with Namir Katkuda to learn the first procedure, advanced laparoscopic procedure after gallbladder, which was a laparoscopic posterior vagotomy with anterior seromyotomy done with the hook. I think we did it for 1 or 2 years because the drugs took over and we were no longer doing any vagotomies or gastrectomies for ulcers. I'm afraid same thing's going to happen to obesity unless we stop shooting ourselves in the foot with these kinds of debates. And we're going to have to, the robot is not going to help. We should look at minimally, even less invasive new types of surgeries because we have only 10 years to go. Thank you.
Oh, agree again. Michelle, you're doing better.
Second time, the record.
Very last comment.
Just very last comment. I'm not afraid of these drugs, not at all. They will open up the door they will come to us because they realize it's not their problem. The stigmatization, they realize that that's the disease and they want to have a permanent cure and we will have more patients to operate. We have to train people.
Maybe we should stop shooting our feet. We should stop this.
At least on that we all agree. And on that note, well, thank you very much, Vincenzo. Thank you, Ricardo. Thank you, the speakers. Very good session. Thank you very much.